Thank you, Dr. Chandrasekhar. Thank you, Dr. Aravind. Very good morning to all of you. Welcome and thank you for coming to this 12th edition of this update in such large numbers and being such an exuberant and interactive audience if the last two sessions are anything to go by. So I've been asked to talk a bit about the updates in diabetes guidelines, specifically concerning hyperglycemia, because subsequent speakers will be talking about the hypertension, obesity and lipid guidelines. So I have no conflicts of interest relevant to this talk. You may take photograph if you so wish, because these are all published documents. So the first thing I did when I was asked to update the guidelines, I looked at the common guidelines, the well-known guidelines which we generally follow, and we find that the ADA guidelines, American Diabetes Association, have been updated in December 2024. The European Association of the Study of Diabetes updated its guidelines in June 2024, which we already discussed partly in the previous edition of the update. The AAC has not updated its diabetes guidelines since May 2023, and the NICE not since June 2022. And I am sure most of you are aware that the RSSDA also has its set of guidelines. The updation of these guidelines is going on, many of us are part of it. So this actually makes my job easy because I only have to talk to you about the updates in the ADA guidelines. And these were published in Diabetes Care in its January 2025 issue as a supplement. Many of you might have gone through it. I'll just try and make it concise for people who have not gone through it or for those who need to revise it. So the first section of the guidelines deals with diagnosis and classification. And here the main update is that there are now treatments available to modify the natural history of preclinical type 1 diabetes, preventing them from developing clinical type 1 diabetes and reducing the deterioration in C-peptide. And these include monoclonal antibodies such as teplizumab, baricitinib, which is a JAK kinase inhibitor, and oral verapamil. That being the case, the ADA now recommends that autoantibody screening should be offered to asymptomatic individuals who are first-degree relatives of type 1 diabetes patients or those who have an elevated genetic risk. Thus far, we were not recommending this because we had nothing to offer them. Now we do. So it's probably reasonable to offer these individuals screening for type 1 diabetes. And now we know the International Diabetes Federation in its last meeting has brought out a new concept of screening for diabetes and pre-diabetes, looking at the 1 hour glucose value in an oral glucose tolerance test. And we have had lots of debates regarding that, but this particular concept has not been discussed in the ADA standards of 2025. It's not that they are not aware of it, because in the last ADA scientific sessions, they did have a debate on this, pros and cons of using the 1 hour value, but it's not found it based in the guidelines as yet. And they do talk about the concept of early GDM, that is gestational diabetes diagnosed in the first trimester, first antenatal visit, which we'll be talking about later on in the update, but they have not recommended any particular test for diagnosing eGDM. They only say that the Carpenter-Couston criteria and the IADPSC criteria are probably not validated for screening for early GDM, but they have not given an alternative. The next section deals with prevention. And the main thing that has come out in prevention is the use of vitamin D. And this is only based on 2 or 3 small studies. We will be talking about this in one of the clinical pearls, which we will have on tomorrow and day after. And there are only 3 small studies with variable dose of vitamin D. So they recommend that more data is needed. And this is in contrast to the Endocrine Society recommendations, which state that vitamin D can be considered in individuals with high risk pre-diabetes to prevent progression to diabetes. And of course, as I mentioned earlier, the use of teplizumab, the monoclonal antibody, should be considered in individuals more than 8 years of age with stage 2, that is preclinical type 1 diabetes, to prevent progression to stage 3. The next section, a lengthy section, deals with assessment of comorbidities. And the first thing they looked at in alphabetical order was the bone health. And here they say that you should avoid medications which confer high risk of fractures, and specifically the thiazolidinediones, to a lesser extent the sulfonylureas, in those with elevated fracture risk. Ensure adequate calcium and vitamin D intake, which we anyway would do. And they also recommend the use of osteoanabolic or anti-resorptive medicines such as bisphosphonates in older individuals with diabetes at high risk of fracture. And please note the BMD T-score cutoff for diabetes is -2 and not -2.5 as in the general population. The FRAC score also needs modification for diabetes. Earlier we were using the cutoff for the rheumatoid arthritis patient, but now we have diabetes specific scores for the FRACs. A big section on sexual health. in which it is recommended that we should inquire about sexual health in everybody with diabetes and pre-diabetes, and in those with symptoms or signs of hypogonadism, you should be screening them using early morning total testosterone. And there is a category of individuals in whom we should screen for ED. These include CVD, retinopathy, neuropathy, chronic kidney disease, long duration of diabetes, poor glycemic control, depression or hypogonadism. And female sexual dysfunction finally gets the attention it deserves. The recommendations state that you should inquire about sexual health in everybody with diabetes and pre-diabetes, especially those who have depression and anxiety or recurrent UTI. And they say that you should screen for symptoms of genitourinary syndrome of menopause. So what's genitourinary syndrome of menopause? It is nothing but your old term atrophic vaginitis or age-related vulvovaginitis. So that should be looked for. The classical symptoms include dyspareunia and anorgasmia. Again, we have a talk on sexual dysfunction in diabetes later on in the symposium. Again, a big section on metabolic-associated steatotic liver disease. Now, the name has been changed from NAFLD NASH to MSLD MASH for various reasons. The recommendations state that you should screen everybody with diabetes and pre-diabetes with a FIB-4 score, even if their liver enzymes are normal. So anyone who comes to you with diabetes, pre-diabetes, you have to do a FIB-4 score, which utilizes your AST, your ALT, your platelet count, and the patient age. And if you have a FIB-4 score, which is suggestive, here the cutoff given is 1.3, you should do further evaluation either by means of transient elastography or fibroscan, or by risk scores such as ELF, the extended liver fibrosis score. If you have elevated liver enzymes for more than 6 months, but the FIB-4 is scored, look for other causes of liver damage. And as relates to therapy, tirzepatide has been added. We had the publication of the Synergy, NASH and other trials, which showed that tirzepatide is useful in MASLD. For weight loss as well as for improvement of the liver pathology and management of diabetes, tirzepatide as well as GLP-1 receptor agonist and pioglitazone are considered as the drugs of choice. And now the latest drug which has come in the pipeline is resmetirom, which is a selective thyroid hormone receptor beta agonist, which has been recently approved in the United States for the specific management of F2, F3 fibrosis. But being a new drug, they restrict the use of this drug to specialized centers. This is a diagnostic algorithm. Anybody with metabolic dysfunction, screen for MASH using FIB-4. FIB-4 is low, you only need to follow them up frequently. If the FIB-4 is indeterminate or high, you have to evaluate further. It is high, straight away refer to hepatologist. If it's indeterminate, check for the LSM using fibroscan or do an ELF score, and then based on the score, you can decide accordingly. And these are the treatments given in the early stage F0, F1, no or mild fibrosis. There is no need of any specific therapy for liver steatohepatitis. But for diabetes and obesity pharmacotherapy, the incretin-based therapies are preferred. There is some evidence for pioglitazone and SGLT2 also. If you have F2, F3, the same treatment recommendations apply for obesity and diabetes, but we now have a specific treatment for MASH, that is resmetirom. And once you get compensated or decompensated cirrhosis, there is no role for any specific treatment for MASH. You can still continue the obesity and the diabetes pharmacotherapy. Of course, taking into consideration the restriction for use of all these agents in advanced liver disease. Again, comorbidities, autoimmune type 1 diabetes. Earlier it was said that you should screen for thyroid dysfunction in everyone. Now they added a line saying if clinically indicated. That means everyone need not be screened. If you have clinical suspicion only, you need to screen. Dental examination section has been added, and it's recommended that dental exam be done every year. Disability, frailty. The issue of older individuals with diabetes is coming up in a big way, especially in India. So you should screen for disability at the initial visit and keep on following up, because people do get older with time and their disabilities may increase. Now B12, again we have a talk in the clinical pearls, in whom we should screen for B12, those on high dose metformin, those who have been taking metformin for more than 4 years, those are anemia or neuropathy, or those who are taking a vegan diet or who have undergone bowel surgery. Lifestyle modification is a big controversy regarding sugar-sweetened beverages and artificial sweeteners. The ADA does not recommend against the use of non-nutritive sweeteners, but they say all things considered, water is better. But non-nutritive sweeteners can be used in moderation and in short term for reducing carb and calorie intake in diabetes and pre-diabetes. The WHO's recommendations against sweeteners were in individuals without diabetes. With diabetes, still there is a role, but if possible, use water. And for Ramadan fast, the International Diabetes Federation has over the last 2 to 3 years, been issuing guidelines, the idea of DAR guidelines. These have now been adopted by the ADA. Screen time has been included in the list of sedentary pursuits, sitting, lying down, sleeping. Now, screen time is also included as one of the things to ask for when you're assessing sedentary time. And now we have gotten so good at reducing people's weight that people have started losing muscle also. So in anyone who is on one of these second generation anti-obesity therapies or who undergone metabolic surgery, you should look for and ask for symptoms and signs of sarcopenia. And this is a very nice diagram. They have divided fasting into religious fasting and intermittent fasting with different implications. Religious fasting, fixed in duration and timing. Patients generally are very highly motivated because they have to answer to a higher authority. And there is a risk of hyperglycemia at the end because they tend to go overboard. And there is dehydration because some fast preclude the use of even drinking water. Intermittent fasting, on the other hand, is flexible. Motivation varies with which side of bed you got out of on that particular day. Hyperglycemia is unlikely. Those who are motivated will have good improvements in hyperglycemia. Others, it is very unlikely. So there's no added risk of dehydration because you are allowed to drink water during your fast. So whatever be the type of fast, you have to assess the hypoglycemia risk, what therapies the patient is on, and assess the risk and advise the patient accordingly. There are certain categories who should not fast, and that should be clearly told to the patient whether they follow your advice or not. As far as glycemic goals are concerned, goals are not changed, but the fear of hypo has to be asked for specifically. Why somebody is not attaining glycemic goals? Is it because they are scared of hypoglycemia? That should be asked for and considered while deciding therapy. Section on hyperglycemic emergencies, a very comprehensive position statement has been published last year by Guillermo Anpieres and its colleagues, and the section on hyperglycemic emergencies has been updated as per this particular position statement. And a very interesting condition known as cannabis hyperemesis syndrome. I think this can only happen in America, talking about not taking cannabis. And the interesting thing they have mentioned is that those at risk of decay should avoid cannabis use. I think everybody should avoid cannabis use, not only just those with decay. But what's cannabis hyperemesis syndrome? This is something which can mimic decay. These people come with hyperglycemia, dehydration, severe nausea and vomiting. They have high serum beta hydroxybutyrate, but they have a normal pH. They have a normal pH and they have a normal bicarbonate level. But when it comes along with type 1 diabetes, there may be a mixed picture and you may miss one or the other. So in order to avoid that, they say those with type 1 diabetes should, they don't even say those with type 1 diabetes, those at risk of decay. That means some type 1s can use cannabis. But I don't think we should recommend that to any of our patients. Pharmacotherapy of hyperglycemia. Now expanded indications for the newer drugs with respect to the latest clinical trials, those with compelling indications. Heart failure with preserved ejection fraction and CKD have been added on as recommendations for semaglutide due to the STEP-HF trial and the STEP-HF trial and as I mentioned earlier, the dual agonist and GLP-1 RAs have been added as treatments for overweight, obesity, and MASLD in people with diabetes. And GLP-1 RA, dual agonist, pioglitazone combinations for biopsy-proven MASH. So 3 additional indications, HFpAF, CKD, and MASLD for these newer agents. We will hear more about this in the subsequent sessions. Now, what is not preferred? Poor old sulfonylurea is not preferred, because due to risk of hypoglycemia. Glinide is also not preferred anyway, we are not using it that much. Insulin also is not preferred as initial therapy, that's interesting. Sometimes we use insulin as the initial therapy in people with profound hyperglycemia. But of course, these guidelines do not apply to those people, just apply to the general janta with newly diagnosed type 2 diabetes. And another interesting thing, until the last year's guidelines, the ADA guidelines was recommending the GLP-1 receptor agonist as the first injectable to use, irrespective of patient status. And now they have modified it, saying that only if there is no evidence of insulin deficiency like hypercatabolic state, ketosis, weight loss, ketonuria, hypertriglyceridemia, in that case only you should use GLP-1, otherwise the first injectable should be insulin. The other point is that since we recommend starting with basal insulin, there is always a possibility of over-basalization. That means we keep on increasing the basal dose of insulin and the patient does not get to target because we are not treating the postprandial swings. And how do you define over-basalization? Earlier it was defined by A1C of more than 8 and a basal insulin dose of more than 0.5 units per kilogram per day. They have expanded the definition. The clinical signals include high bedtime to fasting glucose ratio, high preprandial to postprandial difference. It's called the BAM score, bedtime AM score. It should be less than 50. More than 50, it indicates that you are over basalizing the patient. And this is the ADA's pharmacotherapy algorithm. I am not going to the detail because we will be seeing it many times during the course of this update. CVD prevention with respect to ACE, ARB, MRA, not only you need to measure the electrolytes and creatinine at the initiation of therapy or when doses change, but also at routine visits, because we are now adding on one more drug that can affect the creatinine and the electrolytes, that is the MRA. So many people will be on this combination, so you need to be monitoring them on a routine basis. And we know that these drugs are contraindicated in pregnancy, but they have gone one step further and said that in women of childbearing age who are not able to use reliable contraception, also you should not be using these agents. Lipid lowering agents, I'm sure we'll hear about it when Dr. Narasingan speaks, should be stopped prior to conception, avoided in individuals of childbearing age, not using reliable contraception. Although there is some evidence that statins might be safe in pregnancy, still they are not recommended for use in childbearing women. Upper limits of fasting and non-fasting TG concentrations have also been defined as 150 and 175 milligrams per deciliter. Kidney iron foot, they re-emphasize that ACE inhibitor and ARB has to be titrated to maximally tolerated dose. Now in all the excitement about SGLT2 and MRA, we forget to titrate these agents to the highest tolerated dose. We just keep them at a moderate dose and add the other drugs. But remember, all the trials on renoprotection have been done in individuals who are already on a maximally tolerated dose of ACE and ARB. So that's the first thing to do. And the dose may vary from various reasons, may preclude you from reaching the maximum dose. Dry cough, hyperkalemia, etc., etc. So what dose is tolerated best for that patient, you have to reach to, and then only add the new agents. Dietary protein recommendations have been revised for individuals in dialysis. It has to be increased to 1 to 1.2 milligram per kilogram per day because they tend to get cachectic. And in anyone who has CKD G3 or higher, the recommendation is 0.8 milligram per kilogram per day. In pregnancy, dilated retinal examination recommended in first and third trimesters. Earlier, it was only recommended in the first trimester. Opioids, which used to be part of the therapeutic pathway for painful neuropathy, have now been removed because of risk of addiction. And I was very interested to see what is this Ipswich touch test. I thought it's some big, great test. You know what the Ipswich touch test is? With your ungloved finger, touch the toe and see whether the patient can feel the sensation. You can probably call it the Guindy touch test. We can do it here also. There is no need of going to Ipswich for that sort of a test. And they also mentioned that screen for PAD only if diagnosis alters management. Now they may change it now because you may be aware that the STRIDE trial has been published and that has shown the benefit of semaglutide in in avoiding major adverse limb outcomes in people with PAD. So we do have a treatment for this. So it might change in the next iteration of the guidelines. Special situation in population, finally. Now, in children with type 2 diabetes and adolescents with type 2 diabetes, earlier we only had metformin and insulin as treatment options. But now, GLP-1 receptor agonists have been approved, liraglutide and dulaglutide. I am just waiting for SEMA to get approved in this population. And SGLT2 inhibitors have also been approved. So with these agents available, we might be able to get them to an HbA1c target of below 6.5 without too much of risk of hypoglycemia. In such a case, the guidelines have been changed that you should attempt an HbA1c of below 6.5 in those who are deemed at low risk of hypoglycemia. Pregnancy, I know in many guidelines, especially those in the UK, they tend to use metformin as a first-line agent in pregnancy. I will talk about that in one of my talks in the afternoon. But the ADA still does not recommend any agent other than insulin for use in diabetes in pregnancy. The cutoffs, glycemic targets for people with critically ill patients has been revised to 140 to 180. And earlier, it was one size fits all. Everybody who's critically ill, you have to keep between 140 to 180. But critically ill patients are a very heterogeneous group. Some of them can achieve lower targets. In such cases, you have to try for lower targets. In non-critically ill, still the target remains 100 to 180 is considered to be reasonable. And if anybody who has persistent hyperglycemia more than 180 mg per dl, insulin is preferred. Non-critically ill individuals, even if it's more than 180 milligram per deciliter, just because they are in hospital, you don't have to give them insulin. You can give any choice of therapy you like. This all what we do routinely, but they just put it in print. And most important, GLP-1 receptor agonist and surgery. A big controversy is going on. Last year's AD, I believe there was one whole session on this, whether to stop or not to stop. The anesthetists say stop, diabetologists say don't stop. And the risk being, of course, that we are creating iatrogenic gastroparesis and there is a risk of aspiration. So the 24-hour or overnight fast which we recommend for these individuals may not be enough to empty the stomach. And the situation has become even more difficult with the advent of the longer acting GLP-1 receptor agonist. So most of the anesthesia associations now recommend that the short acting agents which nobody uses nowadays have to be stopped at least 1 day prior. And the long acting agents like dulaglutide and semaglutide have to be stopped at least 1 week prior, if not more. But still there is a lot of controversy going on, and so the ADA says that more data is needed on the best peri-op strategy for these agents. So that's it about the guidelines for diabetes, and I'm sure the subsequent speakers will talk about the rest of the topics in the guidelines that I have not touched upon. Thank you for your attention.